This video describes the step-up approach for using the video-assisted retroperitoneal drainage for pancreatic necrosis after pancreaticoduodenectomy. This is a case of 69-year-old male who presented with 2 weeks history of painless obstructive jaundice. He was found to have a distal CBD stricture on RETROPERITONEAL. An EUS confirmed a dilated common bile duct which was strictured at the distal end. There was solid tissue inside the common bile duct. Biopsy confirmed it as cholangiocarcinoma. Unfortunately, common bile duct couldn't be stented during ERCP because of the tight distal stricture, for which the patient needed a percutaneous transhepatic biliary catheter to relieve the jaundice. The patient developed an ERCP-induced pancreatitis followed by pancreatic necrosis as seen on the CT scan. After a multidisciplinary discussion, the patient was given neoadjuvant radiation, which also allowed a window period for the resolution of pancreatic necrosis. A Whipple was performed after 4 months since the onset of pancreatitis. Pathology confirmed it as T2N0 tumor. Patient had persistent retroperitoneal abscess after surgery, for which step-up approach was employed. The PANTHER trial conducted by the Dutch group demonstrated that step-up approach can decrease the rate of multi-organ failure in patients with pancreatic necrosis. The patient had a drain placed in the left upper quadrant, and then a second drain was placed in the left lower quadrant. The patient had persistent collection with cellulitis despite upsizing both drains. At this point, we decided to do a video-assisted retroperitoneal drainage. We inserted a 5 mm OptiView TROCAR using the lower drain as our guide. This allowed us to enter the retroperitoneal abscess cavity. A second 5 mm TROCAR could not be inserted for camera because of the risk of injury to the descending colon, which was adherent to the lateral abdominal wall on the CT scan. The distance to the retroperitoneal abscess cavity was calculated using the camera and CT scan images. Once we were comfortable with the depth of the retroperitoneal cavity, the 5 mm TROCAR was replaced with a 12 mm large TROCAR and entered the retroperitoneal cavity again. The cavity was irrigated multiple times using the left upper quadrant TROCAR, while the lower big TROCAR was used to suck out all the debris using the suction, which was introduced to the depth calculated earlier. The irrigation was continued till we were comfortable that most of the solid debris was taken out. A customized fenestrated drain was placed in the retroperitoneal abscess cavity, and irrigation was continued for 48 hours after surgery. Patient was discharged on postoperative day 3. He was kept on antibiotics for 4 weeks after surgery. His drains were taken out after 8 weeks once the CT scan showed complete resolution of abscess. Patient was started on adjuvant Xeloda for cholangiocarcinoma. The patient remains well without recurrence at 10 months follow-up. In conclusion, video-assisted retroperitoneal drainage can be used to manage complex pancreatic necrosis even in the background of cancer with good outcome. It is vital to plan TROCAR placement based on preoperative imaging and body habitus to gain the maximum advantage from the VARD's procedure.